Okay, good afternoon, everybody, and welcome to the BJS session, probably the best session of the Congress, so more people should be here. My name is Martin Hübner. I'm working in Lausanne, and it's my pleasure and privilege to chair this session together with Christian Tusso from Geneva. I have to quickly explain you the components of the BJS session. We will start with the prestigious and esteemed BJS lecture, which will be given by Michele Diana, who was the brain of the research unit at IRCADS in Strasbourg, and who joined now the surgical team in Geneva. And then, of course, we have the prize session, and we received the best abstracts. We screened through them for the focus of BJS and for quality, and we selected the best ones. And here at this session, you will hear the four best ones of the authors who also submitted to the rules and submitted their papers to BJS. The winner will receive a substantial amount of money. We'll have opportunity, of course, to publish the work in the BJS. Will be invited to professionally record the presentation for the BJS Academy, and have opportunity to contribute to other academic projects of the BJS Academy. We'll have a fully packed program, and the last thing I would like to say is that the BJS has launched again the most prestigious BJS award to celebrate excellence in surgical science. And please, if you know somebody for his life achievements who deserves, in your opinion, this prestigious prize, you should nominate the person until 21st of June. And without further ado, I would like to give the hands over to my dear friend Michele Diana. You've got 20 minutes to enlighten us.
Pleasure. Thank you so much for having me here. And this is really a privilege of being this session chaired by Martin. We were resident together 15 years ago in Lausanne, and now a Professor Toso that I have the privilege to work with since 4 months. And little disclosure, I'm Chief Medical Officer of a company named Astronize, and I'm a founder. We are moving in this era from the information age to the knowledge age. A patient can generate such an enormous amount of data thanks to robotics, connectivity, that practically speaking, without the help of deep learning, machine learning models, we won't be able to give sense to it. So really, we are in a transition phase nowadays. And the other shift that we are facing is that probably to get out the best of all those technology, we should imagine a new way of treating diseases in collaboration with our colleagues, interventional radiologists and gastroenterologists, into a sort of fusion, into a new discipline that could be named hybrid image-guided surgery. And I was lucky enough to join IRCAD when there was a big grant that we had the opportunity to receive almost $500 million from the French government, 450 million. And this was the trailer that we presented as a concept. So an hybrid room in which multiple imaging systems could be used simultaneously, because those are not mutually exclusive. Those are complementary. They provide different data, and having a system that in the room could fuse the information coming from different imaging systems. And from let's say the project, the dream that became reality, this is the new theater in which we think that the modern surgeon should evolve, obviously full of digital connections, the ability to capture simultaneously physiological data. Imagine that a laparoscope with the insufflator could communicate with the anesthesiologist machine so that the pressure could be adapted simultaneously. And the most important thing, so it's all about imaging, right? What we do like in surgery, unlike what happens when we give a drug. It's very hard to figure it out what happens when a drug is given, which pathway is following. What we like in surgery as physiology mechanics is that actually we see what we do, but we can also see it wrong, right? And this is really, there are misleading situations in which basically we know that the origin of a lot of surgical complications are due to an incorrect appreciation of the surgical anatomy. And in this sense, in this respect, was a really nice case in which the cystic that was really hid by an overlying common bile duct. I will show you in a minute the 3D reconstruction of it. So that's why we need to augment the surgical eye. And the surgical eye can be augmented in several ways, but basically we have categorized in two major augmentations. One is to see by transparency, thanks to a 3D reconstruction of imaging like CT scan, MRI, PET-CT, and also the ultrasound, so a full thickness imaging, but also to see the invisible, thanks to more surface-based imaging, which is the surgical optical imaging, which is also a lot of technologies, fluorescence, multispectral, hyperspectral, laser speckle. And coming back to the 3D reconstruction, so this is now really almost, it's very common, it's very popular. But people tend to think that this is really of a minor help, but this is really not true. There are situations in which the radiologist or even a very experienced surgeon struggles to interpret the CT scan in 2D or without this type of reconstruction, in which you can zoom, you can rotate, you can highlight some elements or hide some others. You see, in this case, we have an anomaly of the inferior mesenteric artery, which has a short common trunk for the left colic. You see on the other side, the more common anatomy, which is much longer. Knowing the situation beforehand was extremely important for the surgical procedure. We published this in the Annals of Surgery some years ago, in which simultaneously we did 3D reconstruction of a cholangio MRI, if you like. We did fluorescence cholangiography and also standard cholangiography. We really wanted to see what were the benefits of really incrementing the number of images that we were taking. And per protocol, the radiologists should have annotated the anatomical variants. In 58 patients, there were 8 anatomical variants. 5 of them, were not seen by the radiologist and were very relevant ones, with anomaly in where the cystic duct was getting into the common bile duct. And you see, this is the image that really was really important to know before. You see, there is this cystic duct that is folded and compressed between the liver bed and the gallbladder. That was really an extremely dangerous anatomical condition due to inflammation that was really important to know as well when planning the intervention. But all of this is time-consuming. It is relatively expensive. And now the ability, thanks to deep learning and machine learning models, is that we are able to really do a 3D reconstruction in a much shorter time. This is a visible patient, is fairly well known as a spin-off of IRCAD. And during the COVID, they did a lot of CT scan for lung, and this provided an insane amount of data that helped to train the algorithms and helped to move from 4 hours, that was the time required to do an annotation and the segmentation, to 9 minutes in fully autonomous way. And this is extremely important also because what we can do with images, we can also extract the features. That's the concept of radiomics. And this project we had at IRCAD, together with Humanitas and Gemelli in Rome, we were able to capture, based on 5 clinical variables and 19 radiomic dimension on 500 CT scans, we were able to capture the possibility to predict liver failure. And we trained 4 different models, the extreme boost, the random forest, the vector machine, and basically we could achieve an accuracy of almost 90% to predict patients that were about to a postoperative failure upon surgery. This is really interesting. And as Vinod Khosla said, there is no reason for a human to read, basically, medical images. But as surgeons, what we like is to have those images during the during the procedure as either as a kind of GPS that can be injected, for example. You see, this is Armando Melani from Brazil, in the IRCAD in Brazil. It can be seen and guide you. He has this tablet next to him, but this is really not, well, it can be helpful, but not that much. What we really like is to fuse this 3D virtual clone of the patient onto the real anatomy into an augmented reality concept. I really love this, this paper that we wrote a few years ago. We called it Towards Cybernetic Surgery. It was a combination of robotics, augmented reality. But basically, the conclusion of this paper is not this wow effect, seeing the anatomy fused with virtual reality. Is that, and that was also said yesterday during the artificial intelligence session, is that the problem with soft tissue, as you will see in a second, is that when there is a deformation of the tissue due to surgical manipulation, what happens is that you lose completely the registration. And we worked a lot on those two main topics, the accuracy of placing the virtual model onto the patient anatomy, and also on how to predict the motion of the organs. And we tried several approaches. I think I'll go rapidly with this one. So this is the possibility to make a mold of the person with a optical scanning. This will help to create literally a mold in which the image can be fused, and that's the type of that's was the scan of this. Alex Ostetler, he was a researcher in IRCAD. That's really is CT scan. Look how beautiful it is projected. And this was the last project before I left, and I still have a PhD student working on this. It's called Disruptor. We got 4.5 million from the region to create a portable system that is capable of making real-time diagnosis of hepatic lesions by ultrasound, but also, thanks to a robotic manipulation, to predict the trajectory that a needle should take to do, for example, a radiofrequency ablation or irreversible electroporation. You see, it recognizes what are the masses in real time, basically. That's how the system looks like. It has never yet been used in clinics, but all the regulatory is ongoing. So you have this ultrasound mounted over a robotic arm. So basically what happens is that you can create a volume because you can control the position of the ultrasound. So it's not random like when it's manipulated by let's say a human radiologist. So this allows you to do volume, and the volume can be reconstructed almost with a CT scan resolution. And this is something that can really be placed in a context of remote telemedicine. And so, yeah. And the other problem is the deformation. And to tackle deformation, there are multiple ways of doing. For example, taking the reference of during breathing, this can be injected, the vector of the breathing can be injected into an MRI and make it dynamic. And so the virtual model that is reconstructed will follow as into a mold, the radiological anatomy. And the most important thing is to use biomechanical modeling. So basically, there is a mathematical properties that will be overlaid on the anatomy that will tell the organ has been moved in this direction with this amount of force. And knowing how the tissue reacts at a certain and given amount of force, particularly with robotics, this is much easier to do. Then you can extract and extrapolate also the position, for example, of the vessel, which are deep-seated. The other important way to augment vision, and which is much easier to do into an operation room, is with the concept of surgical optomics. So the use of light and machine and deep learning to characterize what happens in the surgical scene from the physiological point of view, the metabolic point of view, and also to discriminate a cancerous tissue. I'm sure you are aware about Indosign and Green now is becoming extremely popular. The problem with Indosign and Green is that it diffuses rapidly and is an unspecific dye. With the help of computer vision, we are capable of calculating and quantifying the level of perfusion. You see in this area, the sigmoid is devascularized, but still indocyanine green goes there. But thanks to computer vision, it is possible to compute point by point how the signal evolved over time and assign a value, literally a numerical value, to the different areas, the ischemic and the perfused ones, and convert this into a map that can be overlaid in augmented reality again, and give you basically the lines of resection to cut into a nicely vascularized area. The other extremely fascinating thing about surgical ophthalmics is the use of targeted molecules. You see here, this was Rita Rodriguez, one of my PhD students. She is using the anti-CMET. The molecule is called ME137. And you see in a human specimen that was cut of colon cancer, that was cut at the level of the tumor, you have the fluorophore that is capturing, that is being captured by the tumor cells. And that's how you can see it. And this would be very interesting to use as a way to follow up a patient after neoadjuvant radiochemotherapy to evaluate an oncological response. We have also taken another approach. We have created a fluorophore ourselves that is a polymer that is much brighter than the ICG and that can be used to coat surgical instruments. And with this device, for example, we can coat clips and make them fluorescent so you can see where a tumor is. So your friend gastroenterologist will have put a clip next to the tumor, and from the serosal side, you will know where the tumor is. Or for example, and this is in a human cadaver study, this is a urinary catheter, a double J, that we coated with our polymer, and that's how you can beautifully see the ureter to prevent from injuring it. But the most fascinating thing is endogenous imaging. So it's not fluorescence. This is using other light tissue interactions. And for example, with hyperspectrum, this is a spectrometer and a camera that analyzes the tissue with light, and all the reaction with light will give you the signature of the tissue. But also, for example, the perfusion, because you can measure the hemoglobin, the oxygenated and the deoxygenated hemoglobin in a quantitative fashion. The only problem is that it takes 7 seconds to obtain one image. So this is Manuel Barberio, another PhD of mine, that in this case, it was nicely where the machine is also suggesting. But generally, this does not happen. Basically, our eyes are not good to estimate perfusion, and we are good only in a little more than half of cases, 55%. In the majority of cases, we get it wrong. What we did with this device, much more interesting, is that we use the entire band, not only the band related to oxygenation. We use all the raw data, and thanks to machine and deep learning, we used 14 different architectures in a clinical trial. We were able to identify tumor and project over the tissue, because the spectra is very different between the normal mucosa and the cancer. And with this difference, we are able to use, with a very small data set, so in this case, with only 10 patients, we achieved an accuracy of 93% to identify colon cancer. And when moved to a little more patients, we achieved an area under curve of 95, so a very nice score. And this is Elisa Bonone, another PhD of mine, with 169 patients, part from Strasbourg, part from Verona, using different architectures. She was capable of identifying in an autonomous manner 13 different tissue types with a very, very high accuracy. So I'm about to finish. But what I'm passionate about as well is this new technology. It's a multispectral, it's called Trident. It does simultaneously fluorescence with ICG, but also oxygenation. And it works beautifully with a nice prediction of the level of capillary lactates in the tissue. And we just finalized the first safety trial in Strasbourg. We have seen a lot of technology, but what's the real life? The real life is that there are 5 billion people that have no access to medical imaging, 5 billion. And there are 2.3 billion that have no access to basic surgery. And I personally think that the only way to democratize the access to surgery and to imaging is to move towards an industrial revolution. So to robotize as much as we can, to use the maximum of technology, because what costs a lot in healthcare is not technology at all, is human resources, is us. So the only way, in my opinion, to democratize as much as possible is to rely again and again and more on robotics and imaging and deep learning, so to obtain autonomous diagnosis and therapy. Thank you so much for your attention.